Everyone, welcome to this ASCO GU virtual roundtable. My name is Brian Rini, and I'm a professor of medicine at Vanderbilt and Vanderbilt Ingram Cancer Center. And I appreciate being joined today by several experts in the field, and I'm going to have them introduce themselves, and we will start with Dr. Plimack.
Hi, I'm Betsy Plimack. I'm a GU medical oncologist at Fox Chase Cancer Center in Philadelphia.
And Dr. McDermott.
David McDermott. I'm a medical oncologist here in Boston at Beth Israel Deaconess Medical Center.
Thank you. And Dr. Voss.
Yeah, hi, Martin Voss. I'm a geomedical oncologist also, and I practice at Memorial Sloan Kettering Cancer Center in New York.
Great. I appreciate you all joining us, and you all have extensive expertise in kidney cancer and drug development, so it should be a fun discussion. We're going to touch on several areas in the landscape of kidney cancer, incorporating some of the data that was presented just recently at ASCO GU in San Francisco. And we'll start with frontline clear cell kidney cancer. We'll talk then about non-clear cell. We'll cover some of the other major updates, including the adjuvant setting, and then probably end with, sort of what you're most excited about, as we head into the future and to the main ASCO meeting. I think we'll move on to sort of just a broader field ASCO GU updates. So probably the biggest update there, as you're all aware, was the updated overall survival data from the adjuvant Pembro study. There had been DFS benefit in the first two analyses and papers, and a hint at OS with hazard ratios initially in the 0.5, but not significant and early. And now with what I believe was nearly 5 years of follow-up, there was a significant overall survival benefit, hazard ratio, I believe 0.62, something like that, with Pembro. And then the presentation before that was sort of the other side of the coin with all the other studies which have been negative. This was part B of the Checkmate study, which looked at single agent nivolumab, ipi-nivo, or placebo, which is a complement to the previously reported ipi-nivo versus placebo study, which was negative. And that was similarly negative. One difference being a duration of 6 months of nivo monotherapy versus 12 months of Pembro. But David, maybe we'll start with you, sort of high-level thoughts. You obviously have melanoma experience, with adjuvant immune therapy. Does the overall survival benefit of adjuvant Pembro, how impressive is it, and does it push you to use more of that drug in this setting?
So overall survival benefit is not something we've seen in melanoma, even though we've had these drugs available first for stage 3 and now for stage 2 for several years. And we've yet to see an OS signal, although we do see improvement in metastasis-free survival. Melanoma is a different entity with a different biology and a different recurrence pattern. For example, a lot of the recurrences in the melanoma trials are local, regional, and can be dealt with a second node surgery, for example. The subsequent therapies are probably more active in melanoma than they are in kidney. For example, salvage PD-1 is active in those patients. CTLA-4 is active. BRAF/MEK is much more active than VEGF. So that may explain why we don't see an OS signal there. But I think when you see one, I think two things are true. One, it makes the conversation with patients easier, and in some ways it makes it easier to, in my mind, to recommend the approach. So I do think we'll be using more of it, but I think in general, it was still left with two major problems. We don't know who's going to benefit, and we don't know, which patients are going to recur. So we're probably over-treating still a lot of patients. So we need to insist on better selection tools than we have, also better management and reporting of toxicity. And I think the last thing I would say is the questions that were asked at the end of the talk were really good and didn't get answers. And they have to do with the impact of patients who recurred who didn't get PD-1. And by my math, by the math of those people who were asking the questions, it was about half of the patients who recurred didn't see a checkpoint blockade. We need to know how many of those patients contributed to the early deaths in that study. So are the people dying the people who didn't see PD-1 when they progressed? And if so, then the OS signal is not as impressive in my view, and would once again shape how I talk to patients. We need that information exists, and we need to know it, I think.
Yeah, and just for the audience, the questions, as David alluded to, one of the best questions I think Chris Ryan asked it was, to your point, David, how many of the patient deaths in the placebo arm got PD-1 or conversely didn't get PD-1, right? And if it's 50-50, it's very different than it's 90-10 or 10-90, right? And so, as you say, the data certainly exists. If you have follow-up data and you have survival data, you have both, right? You just need to put them together.
Right.
So yeah, I agree. Impressive data, but the devil's in the detail as always, right? And in this setting, it's very different than the metastatic setting because you're treating people who don't have cancer by definition, right? You're of course you're overtreating, right? By definition, you're overtreating. So I think gives us a little different pause, at least for me, than it does in the advanced setting.
Particularly since we don't see the long-term toxicity data. They report incidence and severity, and then say toxicities were as similarly as reported earlier. I mean, in my mind, that's not good enough. You've got to say how many of those side effects resolved, how many of them are life-altering, how many of them required immunosuppression long-term, all of those things. Because, I mean, to me, I'm obviously an advocate for immune therapy, but when we're treating patients who might not have cancer, I sort of come at it the other way. I don't want to overtreat patients, harm patients, because then what's going to happen in the community is once you've harmed someone with adjuvant therapy, you're less likely to go back at it again if you're a community oncologist, I think, or any oncologist. And that's going to limit the proper application of these drugs, I think, is the tox.
Yeah, no, I think it's a good point. You don't expect the numbers to change, because there's probably not a lot of new toxicity years later. But to your point, it's the persistence of and requirement for steroids and maybe long-term endocrinopathies, things like that, those are the numbers that we really want to know.
And I think it's different analyses that can be done than what we're used to from the metastatic data sets because the treatment is finite. It's like a 1-year therapy. So we can't assume that it must be what we're all used to seeing over time. I also think it's not only about over-treating or harming the patients, which are obviously the big concerns we all have in our minds. It's also about proper education and shared decision-making. We have very smart patients, and they are left to weigh the risks and benefits that we give them. But if we give them incomplete information, it's hard for them. I think on the flip side, one thing that I actually found very helpful, we've all been obviously most keen on seeing the updated overall survival data, but I think it's so helpful to see the updated DFS data for the placebo arm here as we talk to our patients. My own bias has always been that I think, and I talk to patients about this, that there's sort of a very clear tailor the curve, if you will, for patients after nephrectomy. And we tell patients, oh, the risk is the greatest after the first 2 years, and then we space out the scans because it becomes less and less likely that your cancer will recur. And if you look at the curves that Tony showed during the meeting here and look at the placebo, the number of events that happen between year 2 and 3 and year 3 and 4 is just the same. I mean, there's just as many patients that continue to recur, at this point out. They're 50 months out and there's still these events happening. And when we used to tell patients, well, the 2-year, recurrence risk for you is probably somewhere in the 30% range. Long term, it's actually, becoming more clear where these things really fall. And I'm looking forward to seeing these subgroup analyses. I'd really love to see the intermediate high risk placebo curve, because that's, to me, the most helpful one for discussing risk with patients. Those are most of the patients that we see in clinic. Right now, it still has all the M1 patients in there and so forth, but I think that'll be helpful for the future.
Yeah, agreed. Betsy, other thoughts about the data?
Yeah, I mean, just to add to what Martin said about the control arm, there is a lot we can learn from that. I think it is recapitulating almost exactly the ASSURE control arm, which is as expected. We don't expect biology to change as the number of therapies we have changes if we aren't giving the therapy. I think, when I saw that, I immediately start to translate this. How can I present this to a patient in clinic? And thinking it through, I think I would tell that patient, there's a 50 to 60% chance you're cured right now, and that anything we do is over treatment. Conversely, there's a 40 to 50% chance that there's cancer somewhere. We can probably, increase your chance of that cancer not coming back by about 5% with a year of adjuvant pembrolizumab. And that's sort of the basis on which I think we together can make a decision about that. I think one of the other points that was raised during the Q&A at ASCO was, this isn't the best we have, right? We don't give single agent pembro to metastatic disease, we give combination therapies. And is it best for that very high-risk patient to wait a beat, get that first or second scan, when you see them recur, then give them something that has a stronger chance of controlling the disease and yielding, a durable treatment-free survival or remission, as David was saying. So I think, it's philosophical, and I don't know that we have data to answer that question, but it's definitely something I think about in clinic for those very high-risk patients who, I guess it would be intuitive to think they need adjuvant, but maybe they're exactly the patients who will benefit most by waiting and exposing them to IO in a stronger combination.
Yeah, I think the same, probably mostly for those M1 NED patients. I hesitate for just that reason, Betsy, that I think they don't need single agent therapy. They need dual therapy of whatever sort you choose, right? Their recurrence rate is set probably 70, 80%, right? So we just haven't found it yet, right? Very few of those patients are cured. And so I think it's only made the discussion more interesting, perhaps. Hopefully we'll see some of the data and numbers that you all alluded to. Maybe we will, maybe we won't, but at least in the initial publication of this. But I think it's good to ask these hard questions because we all sit in front of patients, and we've had patients have bad outcomes, right, toxicity wise, right, and long term, insulin requiring diabetes and all these things that don't, although they're a little bit of anecdotes per se, obviously they stick with you, and they clearly stick with that patient, right? And so we can't ignore it.
Right, and they add up. We often focus on those that are common, but it's the rare ones that leave the biggest mark on both the patient and the clinician. And you add them up, it gets, I don't know, it's 5-10%, maybe a little higher.
Yeah, I mean, the high dose steroid requirement, I don't know if they updated that. I think it was 8% from the prior presentation. But to your point, David, I mean, it's, what I usually tell people is that, 8 out of 10 tolerate it just fine, but 1 or 2 out of 10 can have serious trouble even lifelong. So it kind of is, depends if you're a glass half full or half empty person, I suppose. But I do think it puts in perspective that rare but serious toxicities, exist and are super important in decision making.
Yeah, and I think that's one way to burn the IO bridge early in this adjuvant setting is if someone hits toxicity. But the other is at progression, would you go at it with a doublet? Would you do an ipi-nivo or a TKI combo and that patient progresses, during the year of treatment? Or do we give up and say they've had their IO, it didn't work, we're moving on to single agent TKI? And I'm kind of uncomfortable with both scenarios, right? So adding and continuing an IO when it hasn't worked feels a little bit wrong and expensive and maybe exposing them to more toxicity. At the same time, saying you got one shot at IO and it was single agent also feels wrong. So I don't know what people think about that.
So the way I see that, sorry. I mean, we have, for adding CTLA-4 to PD-1, we have data in the metastatic setting already, right? So we know that salvage IPI, it is not efficacious for many patients, for few. So I think to go to ipi-nivo then is exposing the patient to high risk of toxicity for a known response rate, which there we don't have good data for how durable that a response might be. Of, depending on what data set you look at, probably somewhere in the 10% range, right? But no CRs reported on any of the trials that have looked at this in a sequencing fashion. So I would not be so attracted to that, knowing, how IPI can get you in trouble on other ends of things. And I would not go personally to TKI IO straight out of PD-1 failure. Given again what we've learned in the metastatic setting with CONTACT-03, where that strategy didn't seem to add much, keeping the IO in place.
Yeah, I guess I'd say this is a big topic that we won't have time to fully cover. But the biology of resistance and can you retreat and what if it's 6 months or 2 years or progress? I mean, this is what we're going to be talking about a lot. And I think the survival data will only increase use, as I think David said. And so this, adjuvant IO resistant RCC population is going to be a growing one moving forward. And you can bet we'll start to see more and more trials in this space. Contact enrolled these people, but there was exactly one patient on each arm. Nivo is, I think, enrolling them. There'll be more. So we're going to start to see some prospective data sets. And you would imagine you will start to see dedicated trials in this space because none of us know what to do and none of it's satisfying. I agree with you, Betsy. I mean, single agent TKI, in my opinion, is the very unexciting standard of care in this setting, but I don't feel good about it. Right. I feel bad about it. Right. And so we need more drugs and more investigation. All right. 2 last things to cover very quickly. One is the adjuvant Nivo negative data, right? So which is basically the same as Ipi Nivo, and all those curves are overlapping. Just maybe real quickly, David, starting with you, any big, how does that impact your thoughts about the Pembro data, and why do you think it was negative?
To me, it makes it easier. The Pembro OS makes it easier not to talk about these other three trials personally,
Fair enough.
which I think is, largely a waste of our time. I think the potential explanation on the Nivo side is less duration of therapy, but that's, who knows. The fact that Ipi didn't add anything to Nivo in that study was not at all a surprise to me, not because I'm sort of clairvoyant, but because we did that study in melanoma, and we did Nivo versus Nivo Ipi, and it was dead negative. So Ipi is probably not, it's adding more tox in that setting where you do not have a lot of, tumor specific immune cells. We've seen it before. Honestly, I think we need to move on to some of these other questions, which are not going to be easy to answer. We do have some answers to these questions in melanoma, because in that melanoma Keynote 054 study, which is the closest, sort of to the Pembro study in kidney cancer, you could cross over to Pembro within the study. So we have a sense of what the activity is for placebo patients getting Pembro, and the response rate was near 40% with 14% CR, so very active. We also know that for patients who were on Pembro and then progressed after 6 months off Pembro, Pembro was still active in some of those patients, far less. I think the response rate was only about 11%. But that suggests that there's some patients, God forbid, might need chronic PD-1, so is that the case in kidney cancer? We need to understand that so we can get to some of these questions. It's going to be hard to do without, trials that look at that concept within the context of the trial. Otherwise, we're just going to be doing all of these sort of retrospective analyses from large data sets, which are not as easy to, it's not as easy to understand responses in that setting.